Hey everyone, I have had a few requests for review of Cpap in our zone, so this is going to be another longer video just to get everyone up to speed. Cpap is one of those things that was unfortunately just super vaguely introduced to medics in our zone just due to lack of clinical resources. So it's understandable that most of us find it a little bit intimidating. Complicating this is the typically declining status of patients requiring Cpap, which is just creating a recipe for panic. You also may have noticed that with the upcoming Care Map update, Cpap has been added to the scope of work document. It is within the scope of a primary level provider and up to be capable of delivering Cpap to a patient that they feel needs this intervention. There is no acknowledgement of a minimum age that a patient must be to receive Cpap, so please use your clinical judgment wisely here. So let's brush up on some Cpap and build some confidence in this skill. Before we get into the specifics of how to actually use our Cpap equipment, we do need to do a review of the respiratory trifecta shown here. These words are going to come up often when we're assessing respiratory patients, and I just want to make sure that we're all on the same page. When we're responding to a patient with any respiratory involvement, including our suspect cardiac patients, what are the three things that we need to be rapidly evaluating to assess the efficacy of a patient's respiratory system? The first step in the system is arguably the most important in the process, being that none of the other steps can happen without ventilation. So what are we looking for in regards to a patient's ventilation? Well, we as medics tend to assess our patient's ventilation as soon as we walk into a scene. Right away, can you tell, does your patient have air entry? And furthermore, is that air entry bilateral? Are we dealing with a pneumo? What is your patient's respiratory effort? Are they really working for it, or is it still pretty easy breezy at this point? What is their rate looking like? And do we hear any adventitious sounds before we've even reached the point of auscultation? These are all pretty good indicators of what our patient's ventilation status is going to look like. After we've established that our patient can ventilate, we need to know about their diffusion. So this is the exchange of gases at the cellular level in the alveoli, and to a degree this can be assessed using SpO2 and now our end tidal as well. If our breaths are not reaching the alveoli for whatever reason, or the terminal airways have collapsed, causing a lack of surface area, this is going to present outwardly as a respiratory problem while the body is trying to compensate and correct that perfusion imbalance. As a reminder, a normal end tidal reading for a conscious and breathing patient is going to be 35 to 45 millimeters of mercury. Anything higher or lower than that is an indication of a problem. And once we've established our patient's ventilation and diffusion status, the last step is going to be perfusion status. So what kinds of things are we looking for in regards to a patient's perfusion? Well, firstly, our basic vital signs are always performed on every patient and are a pretty good indicator of their perfusion status. If your patient's hypotensive, this is indicative of a problem with perfusion that will likely require a little bit more investigation. If your patient's bradycardic, there's likely not enough oxygenated blood circulating fast enough for the body's needs. If your patient is significantly tachycardic, it's likely that this is affecting atrial filling and therefore cardiac output, which is going to decrease perfusion. You get the point. But if we're talking quick and easy assessment of perfusion, we have two things that we tend to do. Right as soon as we walk into a call, we right away can see what our patient's skin color looks like. This is usually a pretty good indication of poor perfusion, especially if it's real bad. I've also included cap refill on here because we do tend to write off cap refill as not as important of an assessment, but the fact of the matter is cap refill is easy and non-invasive and quick. There's nothing wrong with doing a quick cap refill and seeing how your patient is perfusing. As you've probably noticed by now, all of these components go hand in hand and create oxygenation. If a patient seems to be ventilating appropriately but doesn't seem to be perfusing oxygen or vice versa, this is commonly referred to as a VQ mismatch, which we're not going to get super heavy into because we did include it in the last video for capnography. But we do need to do, unfortunately, a quick review. So a normal VQ ratio in a healthy lung is going to be 0.8. We talked about this in the last video. If our patient shifts over to a low VQ ratio, or also known as shunt perfusion, this means that perfusion is functioning appropriately with not enough ventilation. Essentially, the alveoli don't have enough oxygen to exchange, but the blood flow is there and ready to do its part. Moving on to the other end of the spectrum, we have a high VQ ratio, also known as dead space ventilation. This means that our patient is moving air, ventilating well, there's oxygen available in the alveoli, but there is not adequate blood flow to diffuse and carry this oxygen. So why is this important? From a differential diagnosis perspective, a VQ mismatch can be a significant clue as to what's going on with our patient. Some examples of a low VQ ratio would be a collapsed alveoli, which we see in emphysema, increased secretions, obstructing air entry, mucus plugging, and a bronchial intubation. A bronchial intubation, of course, would only cause a VQ mismatch in the opposite lung, but serves its purpose as a good visual. Some examples of a high VQ ratio would include cardiac arrest, pulmonary embolism, and hypovolemia. Okay, so what exactly is Cpap and why are we using it? As indicated on the title page, Cpap stands for Continuous Positive Airway Pressure. I realize that after a while, all the acronyms start to feel a little bit like alphabet soup, and this can cause some confusion. Cpap differs from BiPAP and positive pressure ventilation in the sense that Cpap is blowing pressurized oxygen at the same pressure consistently, regardless of what phase of the respiratory cycle the patient's in. Think of it like a leaf blower for your lungs. BiPAP is also for spontaneously breathing patients, but offers pressurized oxygen delivery at different pressures for the inspiratory and expiratory phases of ventilation. This can be useful for patients who require less airway resistance when trying to expire oxygen or breathe out. Positive pressure ventilation, for the purposes of keeping this ERS relevant, is the act of mechanically ventilating a patient or bagging the patient. This is generally reserved for the non-spontaneously breathing patients or the patients who are headed into a respiratory failure and need some support. The muscles responsible for creating intrathoracic pressure differences that are necessary to breathe are tired and failing, and this patient now needs a higher level of respiratory support. So now that we understand what Cpap is actually delivering, let's think about when and how this would be helpful for our respiratory distress patients. The cool thing about Cpap is that it actually accomplishes many different effects that can improve a variety of conditions. This makes it a lot more versatile than many of us have probably realized. As it turns out, Cpap can treat a whole variety of respiratory ailments. The current shared health patient care maps pertaining to respiratory ailments make sure to mention the consideration of Cpap in each of the algorithms with the usual COVID disclaimer, but not much more information on the criteria of use for Cpap. Like most medical devices, Cpap also has indications and contraindications. So before we start picking through care maps, let's take a closer look at just what we're supposed to be considering. In a very broad sense, you can encompass most of Cpap indications with the phrase individuals that can breathe spontaneously throughout the respiratory cycle, experiencing respiratory distress. Super vague, but I opted to include this because I feel like there is an intimidation surrounding Cpap and also a misconception that your patient needs to be severely ill before receiving Cpap, which is just not always the case. If this broad indication helps you to visualize the larger usefulness of Cpap with respiratory complaints, then cool. But specifically, the uses of Cpap are many. Starting with the most obvious, Cpap is definitely indicated for use with asthma patients. Some of you may be familiar with this graphic illustrating what we're dealing with in an acute asthma attack. We have air trapped in the alveoli, narrowing of the airways, restricting airflow in, and making it difficult to fully expire air from the alveoli. So with this in mind, what is Cpap going to do for these asthmatic patients? Firstly, it's going to reduce the work of breathing for them. Clearly, it's much easier to breathe in when there's oxygen being forced into your airway. This is also going to take a whole load of pressure off of the inspiratory muscles that have been working overtime. Cpap is going to splint open constricted airways, allowing some trapped air to escape. Here's a visual for you. This does apply to asthma, but it is definitely worth noting that this is with the help of bronchodilators. Cpap will have little effect on the tight and smooth muscle that is constricting the airways, and this is what our bronchodilators are acting on. Cpap is going to counteract intrinsic PEEP in these patients. Also read pursed lip breathing. We all know that pursed lip breathing is a common presentation in patients with respiratory distress, but why are they doing it? Turns out it's more instinctual than purposeful, and it's the body's way of trying to push out the trapped air and the trapped carbon dioxide with it, which you would think would be great. However, there's a few problems with this. Pursed lip breathing to create intrinsic PEEP is only sustainable for so long. It's meant to be a short-term solution, like we're talking under 10 breaths, and needs to be performed correctly to have a positive effect. Your patient is going to end up tiring themselves out and heading into respiratory failure even faster. There's also the major issue of air trappers needing little to no PEEP. Intrinsic PEEP is helpful in cases with mildly underinflated alveoli that need a little back pressure to re-recruit. An example would be like Vicky ran up the stairs a little too quickly, and now she needs to do a little pursed lip breathing to catch up and carry about her day. In the case of air trappers, however, the alveoli are already inflated and can't expel the air. Pursed lip breathing is only going to be creating intrinsic PEEP against a swollen and inflamed bronchiole, which is going to accomplish absolutely nothing. Nextly, Cpap is going to reverse areas of atelectasis. As a reminder, atelectasis is the collapsing of the alveoli that can occur for many reasons. The extrinsic PEEP produced by Cpap can re-recruit these collapsed alveoli, creating more surface area for gas exchange, which leads me to my next point. Cpap is going to help maintain gas exchange. The increased pressure that oxygen is being delivered at helps to ensure that some oxygen is still going to make it to the alveoli, even initially when the patient is still significantly air trapping. And good news, the information that we just discussed also generally applies to our chronic bronchitis patients. 2 indications in 1 slide for the win. Our next indication for use of Cpap is also covered in the asthma and COPD care map. The reason we're going to cover it separately is only because of the different disease pathologies. Emphysema still falls under the blanket term of COPD, and Cpap is going to still work for an acute exacerbation of emphysema for all the reasons on the previous slide. Again, without getting too heavy into the A&P aspect of it all, emphysema patients are just slightly different than your chronic bronchitis patients because of the differing damage associated with each disease. While chronic bronchitis and asthma are known to produce excess mucus and narrowing of the airways, like we talked about on the last slide, emphysema acts more on the lung tissue, specifically in the alveoli. Destruction of the alveoli is going to reduce surface area for appropriate gas exchange and decrease elasticity of the lung tissue, leading to more air trapping. So picture that like you take a brand new balloon out of a package, you blow it up, and then you let all the air out. It's never going to go back to the way that it was when it first came out of the bag. It's going to be really deflated and sad looking. That is what an alveoli of an emphysema patient starts to look like as the disease progresses. I've also heard emphysema described as, for my home improvement show fans, think of it like the house flippers, buying this cozy old home, going in, knocking out all the walls. It's now an open concept home, which is super for real estate and not so good for your respiratory system, especially if we're considering that the walls were part of keeping the house standing. So try to think of it like that if that helps. As we mentioned already, the application of Cpap in an acute exacerbation of COPD is going to splint open airways, counteract intrinsic PEEP, and reverse areas of atelectasis. Now, more specifically with emphysema, we're going to improve lung compliance, meaning that we are going to force these stiff lungs to expand with O2, decrease the work of breathing, and let this patient focus their already minimal energy on just expiring air. Moving along in our indications of Cpap use, congestive heart failure is another big one. The term pulmonary edema is still often used interchangeably with CHF. In reality, pulmonary edema is more a symptom of CHF and can almost become a distracting injury in these patients. This feels like a really good time to remind everyone that respiratory complaints should always come with a healthy suspicion of cardiac involvement, and this is why. However, for the purposes of keeping our focus on these shared healthcare maps, we're going to use the term acute decompensated heart failure. A quick reminder of what exactly this means. Your patient is having an acute cardiac event that is causing ineffective blood distribution. They're going to present with a variety of symptoms depending on the area of the heart that's failing, but they can generally be spotted by their chest pain, dyspnea, edema, all those classic cardiac symptoms. Essentially, we're going to be using Cpap for these patients to treat either a dead space ventilation problem, which would be the mechanical failure of the heart to produce enough blood flow to distribute oxygenated blood, or we're going to be using Cpap to treat a shunt perfusion of pulmonary edema. Cpap is very effective in redistributing fluids in the lungs that are a result of left-sided heart failure. Cpap is going to push those excess fluids back into the bloodstream via the lungs. Same way that gas exchange occurs, we're just going to push the fluid back. Cpap is also very effective in reducing preload and afterload, which can give a failing heart a much needed assist and decrease the amount of fluid that the heart already can't pump from backing up into the lungs. So to explain it just a little bit differently, it is going to decrease the preload, which means the amount of blood that is coming back to the heart is going to be decreased, meaning that we'll have less fluid to back up into the lungs when the heart is unable to pump that blood. I'm not going to lie, treating a patient in decompensated heart failure is a balancing act. If we think about the options we have and the potential adverse effects of these tools, it can be a little bit daunting. The first line of treatment for a patient having pulmonary edema is nitro, which we know to cause hypotension due to vasodilation. Hypotension due to vasodilation is known to be accompanied by ventricular dysfunction. In a heart that's already having dysfunction, this is going to be no bueno. Large boluses of fluid are not typically a good idea for patients who are already drowning in fluid backup, so that's probably not a great idea to try either to pump up that patient's blood pressure. And Cpap either can't be used due to the hypotension that already exists or likely will cause hypotension. So I guess the moral of this sidebar is Cpap is very effective in the treatment of congestive heart failure, but don't ever sacrifice an effective blood pressure just to increase a patient's SpO2. Treat this patient as effectively as you can, transport to more definitive care, and be prepared to secure an airway. This one's not necessarily an indication per se, but when I was putting together this slideshow, I did come across quite a bit of information regarding the use of Cpap in patients with traumatic flail chest. Those of you that have been checking out Master Your Medics, you've probably noticed that he talks about it quite a bit as well. So we're going to go over a little bit of information regarding this. This one is going to be labeled handle with care. Flail chest can cause an inability to expand fully when the patient is breathing in, and or an inability to fully exhale due to instability of the rib cage and like pretty significant pain. These patients are usually guarding because of the significant pain in the chest, and they'll be taking those short shallow little breaths just to try and reduce their own pain naturally, which is fine, but this is obviously going to lead to hypoxia, hypercapnia, or some of both. Coupled with outer splinting of the unstable ribs and some pain control, Cpap can provide splinting of the chest wall from the inside, which sounds like a win for the patient. So what's the catch? We are going to cover a little bit more about that in the contraindications section. The contraindications of Cpap are just as numerous, but thankfully pretty straightforward, almost bordering on common sense, so this should be a pretty quick section. The first few contraindications for Cpap use are what we're going to call relative contraindications. This means that we shouldn't use Cpap while patients have these symptoms, but we also have tools in our scope to potentially reverse these symptoms. Take nausea and vomiting, for example. I'm sure everyone can visualize why we wouldn't want to attach a mask with pressurized air to a vomiting patient's face, so I don't need to add that visual in there. Luckily, it is well within our scope to treat nausea vomiting with either dimenhydrinate or metoclopramide at the PCP level and ondansetron at the ICP level. If you're able to manage the nausea vomiting symptoms and no other contraindications exist, congratulations, your patient is now eligible for Cpap. Our second relative contraindication is going to be hypotension, or a systolic BP of less than 90 millimeters of mercury. Some of us come from a time where hypotension called for an aggressive fluid bolus. Thankfully, we're getting very far away from that. That makes this a relative contraindication. It's not quite as cut and dry. We know that in some cases we have the ability to reverse hypotension, but we also know that there are many different causes for hypotension. We need to consider the cause and the likelihood that we're going to be able to reverse it without causing secondary problems. So is our patient just dehydrated from a week-long influenza? Or are we looking at acute decompensated heart failure that will be susceptible to fluid overload, leading to worsening pulmonary edema? If you are able to reverse the hypotension, your patient can now be eligible for Cpap use, but be aware that the reason hypotension is a contraindication is because Cpap itself can cause further hypotension, which we're going to dive into a little bit more later. Our last relative contraindication is likely to be present in most respiratory patients that we're attending to. It's not necessarily reversible, but it's very treatable and supportable. Anxiety in respiratory patients to the point that you are unable to properly seal a Cpap mask on their face is obviously problematic and a frustrating predicament for EMS because we know that treating a patient's respiratory ailment is likely to relieve a lot of that anxiety. But from the patient's perspective, it's difficult to see that finish line. It's further complicated by how uncomfortable and counterintuitive Cpap can feel for that patient, and it's likely to cause more anxiety. It's never a good idea to sedate a patient with respiratory distress, but there is something to be said for an age-appropriate dose of lorazepam. This may provide your patient just enough anxiety relief to tolerate Cpap. There is also a lot to be said for the coaching and emotional support EMS can provide to a patient having anxiety, and this should always be the first line of intervention. We're always going to go supportive care over pharmaceuticals. The rest of our contraindications for Cpap are pretty obvious, but let's run through them. First is going to be a hemo or pneumothorax. We just talked about flail chest being an indication for use of Cpap with thorough assessment, and this is why. Flail chest has a high potential to cause lung injury and subsequently hemopneumothorax, with many of the symptoms overlapping with the expected symptoms of flail chest. Your best indicator will be decreased breath sounds on the affected side. Let's think about the physiology of a pneumothorax, whether it be traumatic, medical, or idiopathic in nature. Regardless of the cause, this patient now has air in the pleural cavity, causing increased intrathoracic pressure. Cpap also causes increased thoracic pressure, and depending on the cause, can introduce even more air into the pleural cavity, leading to faster deterioration of these patients. Ultimately, these patients need supportive care until they can receive a needle decompression and chest tube. Next contraindication is going to be possible upper airway obstruction. This is going to include a foreign body airway obstruction or anaphylaxis. Patients with a foreign body airway obstruction will not benefit from Cpap and will likely be further injured with its use. If they were partially obstructed with a foreign body and you apply Cpap, you're likely going to push the object down and create a worsened obstruction. While anaphylaxis could possibly present with shortness of breath, it's important to fully assess the likelihood of an anaphylactic reaction and treat this accordingly. Both of these differential diagnoses rely heavily on a patient history. Next contraindication is going to be facial trauma as a next contraindication is going to be facial trauma. The contraindication facial trauma, that's a pretty broad term. We want to be able to use our clinical judgment for this one. If your patient has mild facial trauma, like this guy here, and can tolerate the Cpap mask, then absolutely give it a try. With the patient, we have several considerations to make. Is the patient even going to be able to tolerate the mask on this injury? Could this patient potentially have a basal or skull fracture or a nasal fracture that could allow pressurized air into the cranium? Is there likely to be blood or secretions in the airway that we don't want entering the lungs? Assess all of these points and make an informed decision for your patient. So I think we can safely say with this guy here, as long as he can tolerate the mask sitting just on the bridge of his nose there where he might possibly be having some pain, and as long as he doesn't have any extra blood in the airway, we could probably safely consider Cpap for this gentleman. If we're looking at somebody who has quite a bit more significant facial trauma, I think this one is going to be a definite no. There is no way you're going to get a good seal on this patient's face, and I'm pretty sure you don't want to anyways. This patient is going to be a huge aspiration risk with potential for basal or skull fractures as well. And then we, of course, have this patient here. This is just going to be an absolute no. There's no way that the Cpap is going to fit on this patient. There's no way that we can guarantee that this patient's airway has not been injured. We are likely to cause further damage to this patient applying Cpap to them. The last contraindication for use of Cpap is going to be respiratory failure or lack of spontaneous respirations. These patients are now or soon will be at the point that they require mechanical ventilation with a BVM. Their body is tired. They need way more support than Cpap can offer. So how do we recognize impending respiratory failure so we can prepare to secure an airway? A patient in or heading towards respiratory failure will have a few or all of the following indicators. Increased or reoccurrence of anxiety. So that sense of impending doom. Everybody remembers that term from school. These patients are likely to get that sense of impending doom that then looks a lot like a reoccurrence of anxiety. They're also likely to have decreased LOC and muscle tone. So if we were to play this video again, we can see this gentleman here, this patient, he's having a hard time holding his head up. He is chin to chest. He is tuckered out. So he has a decrease in muscle tone and probably LOC as well. Decrease in BP must be accompanied by other failure symptoms, but a decrease in BP is something we still need to keep an eye out for with use in Cpap. Patients that are in or about to be in respiratory failure could also have bradycardia, increased end-tidal CO2, and decreased SpO2. That's kind of the hallmark of respiratory failure, is a hypercapnic and hypoxic patient. So keep an eye on those two numbers and how they are correlating to each other. Otherwise, respiratory arrest or impending respiratory arrest is when to surrender. These patients will soon be unable to breathe spontaneously, meaning the contraindication for use of Cpap. This is the time to secure an airway should the patient tolerate this. Do not sedate a respiratory patient to intubate them. So we've talked about all the wonderful things that Cpap can do for our patients and some reasons to not use Cpap. Let's cover some potential adverse effects of Cpap that we need to be looking out for if our patient has met the criteria for this treatment. You're probably going to notice in this section that there's a lot of overlap between our adverse effects and our contraindications. The first one is going to be hypotension. I know I have mentioned it a few times already and deferred to later, and this is later. So we already know that patients who are hypotensive are relatively contraindicated to receive Cpap. But why does Cpap cause hypotension, and what can we do about it? This is actually pretty simple. The re-recruitment of alveoli and splinting open of the airways is bound to cause increased intrathoracic pressure. So there's less space in the chest cavity, and with too much pressure, we can cause almost a tamponade effect on the heart. This is going to cause a decrease in preload and afterload. And we already talked about this is generally a desirable effect for CHF patients. This can also cause hypotension. Proceed with caution, and if hypotension occurs, try reducing your Cpap settings to the last point that your patient was hemodynamically stable. So for example, if you have your patient, you've titrated them up to 10 liters per minute from your Cpap and you suddenly notice a drop in their blood pressure, you can actually try backing off the Cpap settings, maybe back down to 8 liters per minute, and see if that decrease in pressure helps with the hypotension rather than just throwing in the towel on the treatment altogether. Again, as a reminder, hypotension is going to be considered anything less than 90 millimeters of mercury. The increased intrathoracic pressure can also cause bradycardia. Basically, there are high pressure baroreceptors found in the aortic arch of the heart. Pressure is put on the baroreceptors, which send signals up the glossopharyngeal nerve to the medulla. Medulla confirms signals to slow the heart rate. If this occurs, you can also try reducing your Cpap settings to the last hemodynamically stable point and see if this reverses the effects. If you're lucky enough to have a partner working at the intermediate level, this is also a great time for them to break out the atropine. Bradycardia caused by vagal stimulation is often reversible with atropine and can be attempted before reducing or discontinuing Cpap. We already talked a little bit about anxiety in relation to respiratory distress and the application of Cpap. It also needs to be mentioned that claustrophobic anxiety can occur at any point during treatment and needs to be managed quickly to keep the patient tolerating therapy. This is especially relevant if your patient was on the decompensating end of respiratory distress and has had an improvement of status with Cpap treatment. We don't want them to just rip the mask off their face now that they are physically capable of being combative. They have now probably regained some sense of what's going on. They now have the ability to even be anxious and the energy to be combative. So we don't want them to rip that mask off their face. Barotrauma. You know it's been in the back of your mind since the wacky waving inflatable arm tube man graphic. And this is exactly why we proceed and titrate with caution when we're applying Cpap. We don't just crank it up to 10 liters per minute and force it on the patient's face. We want to start low and slow. We've all heard the saying, you can always add more, but you can't take it back. This is exactly what we're talking about in this case. We're just going to start low and slow and titrate up once we get good compliance from our patient. Speaking of titrating up with our Cpap, once we get the Cpap on the patient's face at our low pressure, we want to keep our increases or our increase in titration at least 5 minutes apart. If you have good compliance from both the patient and their lungs, and there's an improvement in patient condition, there's no need to push your luck and just keep increasing pressure for no reason. Once you have found that improvement sweet spot for your patient, we're just going to leave it right where it is. GI distension, which can obviously lead to vomiting. We're going to want to keep a close eye on your patient's physical appearance because it would be preferable to catch GI distension before it turns into vomiting. I'm sure everybody can probably picture why, but just for the sake of saying it, obviously if we are forcing air into a patient, there is a high potential for some of that ending up in the GI tract as well. Same as when we're bagging a patient during CPR, we always want to be mindful of any GI distension. If you are starting to notice any of that in your patient, same as many of the other adverse effects of Cpap, you can just back the pressure off and see if that helps. Right now, Cpap in the province is a little bit of a free-for-all with the equipment. It's an eventual goal of standardization to get all the zones using the same equipment, but for now, we all have our preferences in each zone. Here in the North Zone and also in the East, we are carrying the O2 Cpap device.
Being a more simplistic version of Cpap, it is easy to set and maintain and only requires an oxygen source. The chart I have here shows the correlation between the increase in the O2 flow rate and the increase in pressure delivered to the patient measured in centimeters of water. This chart gives the impression that the minimum flow rate for this mask is 8 liters per minute of oxygen, giving a pressure of 5 centimeters of water. However, when I reviewed the paper instructions included with the Cpap, they do imply that one could actually set the Cpap up as low as 1 liter per minute of oxygen. So given this variability in the different sets of instructions, I would suggest setting a starting flow rate of 5 liters per minute just to help that patient gain compliance and gain good lung compliance and hopefully a little bit of improvement. I also have here a QR code linked to a YouTube video demonstrating setup and use of the O2 Cpap system. I'll give you a few seconds to scan this code with your phone if you wish to watch it.
As a final note, Cpap is still considered an aerosol generating medical procedure. However, in the 11th hour before I was able to get this video out, we were informed that PPE guidelines for AGMPs will be changing with the Cpap updates on May 15th. The updated document for AGMPs has not been uploaded to the Coming Soon folder, so please make sure to review it when it is released on May 15th. The notable changes in the document include acknowledgement that COVID is not the only transmittable respiratory illness that healthcare professionals come into contact with, and a relaxation in required PPE for AGMPs. What you're required to have donned during AGMPs depends entirely on your patient's presentation, recent history, and clinical suspicion of a transmittable respiratory illness. Basically, it's going to boil down to this. If you suspect that your patient is symptomatic of a transmittable respiratory illness and requires an AGMP for treatment, you are required to be wearing appropriate eye protection, a fitted N95 or half mask, and the usual gloves while performing this procedure. If you believe your patient is symptomatic of a more chronic respiratory condition as opposed to a transmittable illness, you may choose to wear an N95, a surgical mask, or no mask while delivering an AGMP intervention. This is obviously dependent on the clinical situation, with a continued emphasis on protecting yourself. This document has been updated to reflect the recent changes in routine practices with shared health, with an emphasis on point of care risk assessment. You'll probably notice that the individual care maps like asthma and COPD still have instruction to don extended PPE for any AGMPs. The new AGMP document and Shared Health's Return to Routine Practices document trumps these, and we'll hopefully see these changed in the near future. Thanks everyone for sticking with me in this longer video, and I appreciate your continued feedback on which skills might need a review in this zone. I was not able to get PowerPoint to work with me this time, so please be sure to head over to the much shorter video on the practical review of Cpap use. As always, be sure to contact your clinical team if you have any additional questions regarding Cpap use after your review of this Cpap package. Thanks so much, everyone.